Hello, Namaste. Today we will study about coronary heart disease. It is one of the non-communicable disease. That is a disease that will not spread from one person to another. Coronary heart disease or CHD is also known as ischemic heart disease. And a definition is given for that. It is the impairment of heart function due to inadequate blood flow to the heart compared to its needs caused by obstructive changes in the coronary circulation to the heart. So, there will be improper functioning of the heart due to the inadequate blood flow to the heart when compared to its needs. That is, for the functioning of the heart, there needs some amount of blood circulation, but this circulation will be hampered mostly by any obstruction in the circulation due to the plaque deposition. So you can see an image here which shows the plaque deposition, which will result in the obstruction to the blood flow leading to heart disease. So this image can be remembered while writing the definition. Okay. CHD causes 25 to 30% of death in most industrialized countries. Maybe because of that, WHO called CHD as modern epidemic. So, next is how CHD is manifested, or what are the signs of CHD. So, CHD may manifest as angina pectoris of effort, cardiac failure, myocardial infarction, irregularities of the heart, and sudden death. So, ACMIS, angina, cardiac, myocardial, irregularities, sudden. So, these can be remembered by ACMIS. Among these, myocardial infarction is very important to remember, as this is very specific to CHD. So, next is about measuring the burden of the disease CHD. For that, we can use proportional. The first one is proportional mortality ratio. It is the simplest measure, that is, it is the proportion of all death due to CHD to the total number of death. The second is loss of life expectancy. Since CHD cuts short the life expectancy of an individual, it can be also used as a measure to burden the CHD. Third one is CHD incidence rate. Hope everyone know incidence always refer to the number of new cases only. So, this is the sum of or the total of fatal and non-fatal attack rates. Fourth one is age specific death rates. Nowadays the CHD is very common among youngsters also. So, the age specific death rates are used to measure the disease burden, since it provides the knowledge about the age-wise increase in the incidence. The fifth one is prevalence rate. It always refers to calculating the old and new cases of CHD. So, in incidence, only the new cases are included, whereas for the prevalence rate, we calculate both old and new cases. Next is case fatality rate. It is defined as the proportion of attacks that are fatal within 28 days of onset. And the next measure is measurement of risk factor levels, like measuring the levels of cigarette smoking, hypertension, alcohol consumption, and serum cholesterol in the community. So, we will deal with all the risk factors later. So, here the measurement of risk factor level is also used for the measuring the burden of the disease CHD. And last one is medical care, that is measurement of levels of medical care in the community. Next, we will deal the epidemicity of the disease CHD. So, there is a changing trends in the incidence and prevalence of CHD. That is, countries where the CHD was an epidemic earlier are now showing a decline. and earlier it was the disease of the higher social classes, which have changed now. Means now the disease is seen among the low income community also. So to study this or to measure the trends as well as the determinants in CHD, like related to incidence, prevalence, mortality, morbidity, risk factors, etc., there was an international project for WHO naming MONICA. It is an acronym for Multinational Monitoring of Trends and Determinants in Cardiovascular Disease. Even though there is a decline in incidence and prevalence when compared to past, CHD is still the most frequent single cause of death among men under 65. Okay, still it is one of the most frequent cause of death. And current status in India shows various studies show the prevalence of CHD is more in urban areas when compared to the rural areas, and the prevalence is more among men when compared to women. Next we will study about the risk factors. A table is given in the textbook which explains the modifiable and non-modifiable risk factors. Modifiable means we can make some changes in the risk factors, like if the person is a smoker, we can advise to quit the smoking, like that. If the person have hypertension, we can advise to have the medicine or change in the lifestyle, etc., depending on the level of hypertension. And the non-modifiable means we cannot make any changes in that factors, like the age cannot be changed, the sex cannot be changed, family history, like that. So the importance of risk factors is the greater the number of risk factors present, the more likely the person will develop the CHD. The principal risk factors among non-modifiable includes age, sex, family history, genetic factors, and personality. Whereas the modifiable risk factors include cigarette smoking, high blood pressure, elevated serum cholesterol, diabetes, obesity, sedentary habits, and stress. Among men, it is 60 years, and among women, above 70 years is considered as a risk factor. And sex, we already discussed, men is more prone for the disease when compared to women. And not all the risk factors are detailed in the test. The detailed ones are, first one is smoking. Smoking is a major CHD risk factor. Due to smoking, there will be carbon monoxide induced atherogenesis and nicotine stimulation of adrenergic drive, which raises the blood pressure and myocardial oxygen demand, and it also affects the lipid metabolism. So there will be atherogenesis and adrenergic drive, raising the blood pressure and oxygen demand of the person. It also affects the lipid metabolism. The degree of developing CHD is directly related to the number of cigarettes smoked per day. Also, the risk of death from CHD decreases on cessation of smoking. So there is a it can be reversed. The risk factor level can be reversed in a person if he quit the smoking. Next is hypertension. The blood pressure is considered as the most useful test for identifying high risk individuals of CHD, and hypertension accelerates the atherosclerotic process, especially that is the formation of plaque, especially if person has hyperlipidemia also. So if the person is hypertensed, if the person have hypertension along with hyperlipidemia, there's a chance for atherosclerotic process in him. So there's a high risk of developing CHD. The third point is serum cholesterol. Here it refers to the lipid abnormalities. So elevated serum cholesterol, especially we all know the LDL, is most directly associated with CHD. We all know HDL cholesterol more than 40 mg per dl is protective against the development of CHD, and the recent evidence indicates that HDL and LDL subfraction levels are better indicators of CHD than this LDL and HDL cholesterol. Then come to the other risk factors. First one is diabetes. The risk of CHD is 2 to 3 times higher in diabetics when compared to non-diabetics. The second one is genetic factors. A family history of CHD is known to increase the risk of premature death due to CHD. Third point is physical activity. We all know sedentary lifestyle is associated with the development of CHD, and there is an evidence that regular physical exercise increases the HDL level, the good cholesterol, and it also decreases the body weight and blood pressure, which are considered to be beneficial for cardiovascular health. Fourth point is hormones. It's a hypothesis that hyperestrogenemia may lead to atherosclerosis and its complications such as CHD, stroke, etc. The fifth point is type A personality. Type A behavior is associated with competitive drive, restlessness, hostility, and impatience, and they are more prone for CHD than the calmer type B individuals. The sixth point is alcohol. High alcohol intake, defined as 75 gram or more per day, is a risk factor for developing CHD. Seventh point is oral contraceptives. The risk of myocardial infarction in women seems to be increased by oral contraceptives. We already came across the fact that the women above 70 years are more prone for CHD, but the risk among women increases by the intake of oral contraceptions. And finally, the miscellaneous factors includes low dietary fiber intake, high sucrose and soft water intake, dyspnea on exertion, low vital capacity, etc. All these are cited as possible risk factors for developing CHD. Coming to the prevention of CHD, CHD is a preventable disease, and for that WHO recommends 3 strategies, like the population strategy, which is subdivided into prevention in whole population and primordial prevention in whole population. Second point is high risk strategy, which is subdivided into identifying the risk and specific advice, and the third strategy is secondary prevention. So the first point, in population strategy, they are focusing mainly on the control of risk factors in whole population, and hence not the individuals are focused here. This is because CHD is considered as a mass disease, okay, and this works on the principle that even a small change in risk factor levels in total population can achieve a biggest reduction in mortality, and the aim is to shift the whole risk factor distribution into normalcy. That is, the aim is to remove the risk factors from the society. For this, some specific interventions are required on the population basis, like the first one is dietary modification. It includes reduction of fat intake to 20 to 30% of total energy intake, limit the consumption of saturated fats to less than 10% of total energy intake, reduce dietary cholesterol to below 100 mg per 1000 kilocalorie per day, increase complex carbohydrate consumption, like the intake of vegetables, fruits, whole grains, legumes, etc. Avoid alcohol consumption and reduce salt intake to 5 gram daily or less than 5 grams. And when smoking is considered, the goal is to achieve a smoke-free society. And to achieve this, a comprehensive health programs would be required, which includes effective information and education activities, legislative restrictions, fiscal measures like inducing the taxes, and also conducting smoking cessation programs. The third point is blood pressure. Here the goal is to reduce the mean population blood pressure levels, which involves promoting a prudent diet. So the goal is to reduce the population blood pressure by promoting the prudent diet, which includes reduced salt intake, high fiber intake, and avoidance of a high alcohol intake. Along with prudent diet, we also recommend regular physical activity and weight control, because all this helps to reduce the hypertension. Fourth point is physical activity. Regular physical activity should be a part of normal daily life. Next is about the primordial prevention. Primordial prevention strategies for world population involves preventing the emergence and spread of CHD, risk factors, and lifestyle that have not yet appeared or become endemic. That is, when we consider a place where the CHD risk factors and lifestyles have not yet appeared. So there is no risk factors and lifestyle in that place. So we are doing some activities to prevent the emergence of these risk factors and lifestyle. So these includes the primordial prevention. How we can do this? How can we prevent the emergence? By preserving the traditional eating patterns and also advising them to follow a healthy lifestyle. Okay, next, several well-planned risk factor intervention trials had been conducted in different countries, demonstrated that this primary prevention can achieve substantial reduction in the incidence of CHD, and they are the multiple risk factor intervention trials conducted in the US, the Stanford Heart Disease Prevention Program conducted in the California, and the North Karelia project of Finland. Moving to the second strategy after the population strategy, that is the high risk strategy. It includes first identifying the risk persons by checking the blood pressure and serum cholesterol, or by checking or asking whether the person is an smoker, or whether there is any strong family history of CHD, or diabetic, or whether the person is obese, or if it is a young woman, asking them whether they are using or taking any oral contraceptives. So after identifying the risk personalities, next is providing them with a specific advice depending on their risk factor. For example, elevated blood pressure should be treated, or the patient should be helped to quit the smoking habit, or if the serum cholesterol concentration is high, it should be reduced. All these included in the must be included in the specific advice. And the high risk intervention studies like Oslo Heart Study and Lipid Research Clinic study shown that it is feasible to reduce the CHD risk factors. After the second strategy, we are moving to the third strategy, that is the secondary prevention. It is the continuation of primary prevention with an aim to prevent the recurrence and progression of CHD through drug trials like use of any beta blockers, or through coronary surgery, or by the use of pacemakers. Next we will go through the revascularization procedures for the angina patients. There are two procedures. The first one is coronary artery bypass grafting, or simply known as bypass surgery, and the second one is percutaneous transluminal coronary angioplasty, or in simple terms known as angioplasty. So the first one, the images are given here. This is the image for coronary artery bypass grafting. So in coronary heart disease, there will be obstruction in the coronary vessels, and through this bypass surgery, the blocked or obstructed vessels are bypassed with a piece of healthy blood vessel taken from any other part of the body, usually from leg or arm. Okay, so the obstructed blood vessel will be bypassed using a healthy blood vessel. And the next one is percutaneous transluminal coronary angioplasty. This procedure is performed to widen the narrowed or obstructed blood vessels. So the blood vessel will be narrowed by the obstruction, by the plaque deposition. So this will be widened using stent. And finally we will study who all are indicated for this revascularization procedure. So this includes the first point. There are 5 points. The first one is patient with symptoms despite taking medical therapy. Even though the person is taking medicine, he is still continually having the symptoms. Second is patients with left main coronary artery stenosis more than 50% with or without symptoms. So there will be more than 50% of stenosis. Third is patients with 3 vessel disease with left ventricular dysfunction. Fourth one is patient with unstable angina and under medical therapy, and still they continue to exhibit ischemia or on exercise testing or monitoring. And the fifth one is post myocardial infarction patients with continuing angina or severe ischemia on non-invasive testing. So next is about the risk factor intervention trial. We already came across these intervention trials while studying the prevention of CHD. So if you are interested to know more about the intervention trials, you can go through the notes which are detailed in it. I have detailed all these. And so that's about the coronary heart disease. So today we studied the definition, how CHD is manifested. We studied the how we can measure the burden of the disease, about the epidemicity and risk factors for CHD, and finally the prevention of CHD, which includes population strategy, high risk strategy, and secondary prevention. So also the revascularization procedures. Okay, so hope all of you understood the topic. If you have any doubts related to this topic, please use the comment box. Thank you.